Welcome to the IAPB Africa webinar on the Primary Eye Care Training Manual. This is our second webinar. Some of you may have joined our last webinar on the WHO core competencies for eye health workers in the Africa region. And when we held that was actually, we had a record turnout for attendees on an IAPB webinar. And I'd like to say congratulations to you all, because you've beaten that last record. Last time round, we had 120 people register, and this time round, we've had 150 people register. So thanks to all of you for joining. We're delighted, and we like that this lays down a challenge to the other regions. So great to have Africa leading on that. So as you all know, today we'll be discussing the WHO AFRO Primary Eye Care Training Manual. Primary eye care is the health component of primary healthcare, and the concept of primary healthcare was proposed more than 30 years ago with the declaration of Alma-Ata as a way to improve fairness in access to healthcare and efficiency in the use of resources. The Global Action Plan for Universal Eye Health was designed to support the integration of eye care into the health system, and specifically the inclusion of the primary eye care into primary healthcare. IAPB has been involved in this, providing technical inputs into the development of this document as early as 2012. From there, we know that the development has been going on for a long time, and it has been quite comprehensive. And we were delighted this year when, in June, WHO AFRO launched the Primary Eye Care Training Manual. The purpose of this manual is to provide guidance in the design, implementation, and evaluation of a course that aims to build and strengthen the capacity of health personnel to manage patients at the primary level health facilities in the African region. And to tell you more about it, we have two speakers who've been involved in the development of the manual since its early days. Firstly, we have Dr. Ciku Mathenge of the Rwanda International Institute of Ophthalmology, who was the technical advisor to WHO AFRO in the development of the training manual, and she also happens to be an IAPB Eye Health Hero. She will be presenting on the manual itself. In addition, we have Dr. Wiafe, who is the chair of the IAPB Working Group on Primary Eye Care, and he will be presenting on the impact that this tool could make at the country level. Just to give you a quick brief on the format of this webinar, we'll begin with the presentations from both of our speakers, and then we'll have a brief question and answer session. So if you do have any questions during the course of the presentations, I'd ask you to type them into if you look at the right-hand side of your screen, you'll see a questions, you'll see a little section for questions. If you click on the arrow pointing sideways, there'll be a drop-down, and you'll have, there'll be a window where you can type questions in. Please type your questions there. We'll compile those questions and then feed them back to the presenters once they've both made their formal presentations. So at this point, I'd like to hand over to Dr. Mathenge to take over and present on the manual itself. Thank you. Over to you.
Thank you, Simon. My name is Ciku Mathenge, and like Simon said, I was the technical advisor in the development of this manual. My talk today is going to be structured as follows. I will tell you what the manual is, why WHO AFRO was interested in developing this package, what is the rationale used in its development. I'll also talk about what the package is and what it is not, what process WHO AFRO followed in its development, and finally, I'll go through the components of the training manual, and together we'll go through it step by step. So as Simon said, the package is a set of tools that has been developed by WHO Regional Office for Africa, and it did this with support from IAPB. And the aim was to increase the capability of health workers who work at the first level of the health system so that they can improve their management of patients who come with eye complaints to these facilities, whether they are dispensaries or health centers. Why was WHO AFRO interested in developing this package? At around the time when the development started, WHO had developed a package called WHO PEN, which is a package of interventions for managing non-communicable diseases at the primary level. And this was being rolled out in member states. However, it was realized that it did not include any package for eye problems, and yet avoidable blindness had been earmarked as a significant problem on the continent. So there was a need to develop a package of interventions that could complement and supplement the WHO PN package at the primary level. And I don't know whether you know, but the eye health desk at WHO falls under the non-communicable diseases desk. So this was very complementary to the whole process. So what was the rationale used by the consultant, myself, and the experts in developing this package? So at that time, there was consensus that primary eye care was important, and there was need for making eye care more accessible to everyone, everywhere. So the same thinking around primary health care. However, there was need to find some direction in the definition of who is a primary eye care worker in the African region. There was much confusion around that. Secondly, there was a need to define what I like to call decision-altering tasks the primary eye care worker should and could perform. Once there was clarity on those two things, then we needed to develop a clear set of competencies that the primary eye care worker needed to have. And finally, all that was put together as a training package, which is supported by protocols that could be used in training the health workers for primary eye care. So that was the general rationale that was used in its development. So I will now look at what the package is and what it is not. So first, let us look at the definition of a primary eye care worker. The definition of a primary eye care worker is a health worker, not a community volunteer, not a primary school teacher, not a social worker, but someone who has had formal training in the health field, not specific to ophthalmology, who now wants to have some skills in eye care. So, for example, an ophthalmic nurse is not a primary eye care worker. An ophthalmic clinical officer or an optometrist is not a primary eye care worker. They are specialized eye workers. But a GP, a general nurse, or a clinical officer, or public health officer, or an assistant medical, a medical assistant, they can all use this package if they are working in the first level of the health system and are meeting patients who present with eye problems. This set of tools can be used as a form of triage for patients presenting at this level, and the package will guide this health worker on what they can treat with medications that are easily available for them to prescribe at that level. It will help the healthcare worker to know how they can offer first aid when needed, what messages they can use to advise or educate either individual patients or communities. It will help the healthcare worker to know what must be referred, either urgently or non-urgently, including where to refer and how to refer. Then the manual also provides all the skills that this health worker needs, either to examine the eyes, to treat the eyes, to advise, to educate, or give first aid. Everything he needs is included in the form of protocols in the manual. So what process did WHO follow in developing this manual? As you know, WHO usually follows very rigorous processes before a package is released, and the same is true for this manual. So first, the background work was done by a consultant who then developed the algorithms and compiled the protocols. After that, WHO AFRO brought together a panel of experts from Africa and from around the world to validate the ophthalmic accuracy of the algorithms and the protocols, and they were refined by consensus from this expert group. In fact, at that stage, the algorithms were reduced from 7 to 5. This was then followed by field testing of each algorithm to test for ease of use, for its sensitivity and its specificity in doing what it said it would in real world situations. So this was done in eye clinics in the field test country. And this was absolutely necessary because the algorithms are the backbone of this training curriculum. After that, a smaller team came together to develop the actual delivery package in the form of a curriculum for training the healthcare workers. Following that, then the consultant developed the first draft of the entire manual, which was then piloted in 2 countries. This was followed by revisions before settling on the manual that is now available. So what are the components of this manual? So as I said, the manual is organized around a set of algorithms or flowcharts. And these flowcharts set out to cover most, if not all, of the signs and symptoms that would make someone seek help for their eyes at a primary health facility. The flowcharts are organized in a way that they show what to ask the patient, what to test, and what to do as an intervention for each patient presentation. The manual also includes a set of protocols which show the primary worker how to test or examine the patient, for example, how to test vision, how to carry out the intervention, for example, how to make an eye patch. And it also includes the list of the health messages that are used either to advise patients, for example, a patient who needs advice on protective eyewear, or groups of patients, for example, if the health worker was expected to educate people living with diabetes on what is good for their eyes. The manual also includes a list of all the materials and the medicines that will be needed out to carry out primary eye care. And finally, all these things are then organized into a curriculum so that a 3-day workshop can be carried out, and it includes the lessons, the lesson plans step by step on how you as a qualified eye worker can train health workers to use this curriculum, including checklists that help you to ensure that learning is actually taking place in the workshop. All that is part of this manual. So now let us look through the actual manual step by step, and I'm going to share my screen so that we can go through the manual together. The manual is available online, and I'll just click on the online link and hope it opens. Yeah. I'll start looking at the manual backwards. So I said that the algorithms are the backbone of the curriculum, and these are the 5 algorithms. I'll just start with the simplest one, which is algorithm number 1, loss of vision. And what is shown here is, in terms of vision, what would a person come and say at a clinic? And a patient would either come and say, I don't see close, for example, when reading, or I don't see far, or my vision is blurry. Those are the common presentations around vision. So using this algorithm, if we could use the the tree that says, I do not see far, the first thing that the primary eye care worker would need to do is to measure distance vision. So within the manual, anything that is blue on the algorithm, there will be a protocol showing how to train the health worker to measure vision, and a checklist that you will use during the training to check that they have learned how to test vision. So you will find a protocol on how you measure distance vision. The outcome would be either that vision is normal or the vision is abnormal. If the vision is normal, then we go down and we find that the intervention is reassure the patient. So within the manual, you will find a protocol that tells you what do you tell the patient if you want to reassure them that they should not worry. If we go to the other arm of the tree, you examine the distance vision, you measure the distance vision, and you find that the vision is abnormal. The primary health worker should ask the patient, did this happen suddenly or did it happen gradually? And if the patient says, I lost my vision suddenly, then that is usually an urgent ophthalmic disorder, and the only intervention they should do is to refer the patient urgently. If, on the other hand, the patient says that I lost my vision gradually, then they can, sorry, I don't see my screen so well. The intervention will not be an urgent referral, but rather to advise the patient that they do need to be seen by a specialist, and therefore tell them where to go to see the specialist. So that is generally what happens with each of the protocols. Now, if we look at the same algorithm, you will see on the near vision side that we have an orange box which says refer for reading glasses or provide them if available. In that case, within the manual, there will be a protocol that teaches the health worker what you do if you're going to provide the glasses. So how do you test for near vision and how do you prescribe them? Or in countries where this would not be available in a primary healthcare facility, then how you refer the patient for glasses. So the algorithms are designed to be flexible and to be country specific so that the interventions are tailored to be what is appropriate in each country. Just go through one more. Maybe I'll go through the last one, which is the one for children, algorithm number 5. Algorithm number 5 is specific for children because most problems in children do need to be handled with care, and that is why it was necessary to have an algorithm for children. You will find that there are interventions in green. Anything in green is something that the healthcare worker can do at their facility. So blue, we said, is something they need to test, and there will be a protocol to tell them how to test. Green means they do something there and then. So for example, if a child came in and the mother says, the color of my child's eye does not look normal, maybe it's a white eye, you might be thinking of vitamin A deficiency, but for this health worker, they will examine the child's eye and confirm that yes, there's a problem. And then if the child happens to be having measles or diarrhea, their action is to give vitamin A to that child. And for that, they will use the IMCI guidelines, which they should already be familiar with. On the other hand, if, for example, we have a baby or a child who has severe infection, we expect the health worker to clean the eye, and there's a protocol for that, to start on antibiotic drops, and there's advice on which drop to use. And if the child has a fever, to give an antibiotic injection as they would under the IMCI guidelines, and then refer immediately. So you will have noticed by now that there is a color coding to this manual. Red, you refer urgently. Orange, you refer but not urgent. Green, you do something. Blue, you do a test. And all the protocols to allow you to do all these interventions are there. So those are the things that are in the rest of the manual. So you will find that the first part of the manual is a summary of the 3-day workshop. The second part of the manual is the component of the lesson plans of the workshop. Let me see if I can scroll to the top. And the lesson plans are really detailed. They tell you exactly things like bridge the participants, hand out this, give them this. So everything is there and it's set out as a 3-day workshop. There's also a column showing you what you need in preparation for that specific lesson. And there will be a section with all the protocols with a lot of photographs showing you things like how to instill eye drops. My mouse cannot scroll fast enough. Yeah, so there will be a section with the protocols as well, clearly shown in clear photos. How do you invert an eyelid? How do you test near vision? And then there will be a section with checklists, which are the tick boxes that a trainer would use to ensure that during the workshop, people are actually acquiring the skills that they set out to acquire. Let me see if I can get a checklist. So these are some of the pictures that are in the diagram. This is testing for near vision. Before each protocol, there's a list of what you need with clear explanations of how you prepare the patient, then the steps of the test, and how you interpret the results of what you find. And the checklists look like this. So for example, this is a checklist on managing a person with an eye problem. So when a patient with an eye problem first sits in front of you, what do you do? So sit the person comfortably, greet the person, ask, why did you come to see me? And these checklists are designed to be used in groups so that someone is assessing what the trainee is doing and grading them on how they are performing. And this is done on a rotation basis. So I just wanted to show you one of the checklists. And basically those are the key components of the manual. I'll now stop sharing my screen and I am going to just conclude my talk and hand over to my colleague. So in summary and the next steps, this is a package with a curriculum and tools for health workers who have had no specific training in ophthalmology to strengthen their capacity to manage eye patients at first-level health facilities. It is a complete package based on 5 algorithms or flowcharts, you can call them flowcharts, which aid the decision-making, protocols for interventions, list of materials and consumables, and a training curriculum as well. And if one is interested in using the package, what I would advise is that you invest in using it correctly. So inform WHO AFRO to link you to a qualified trainer who understands the package clearly and who can train your teams. And WHO will guide you on how to establish a core training team in each of your member states to roll out the training. You need to ensure that your health system has the required supporting structures for implementation, such as the supply systems for materials and drugs, monitoring systems, so that the trainees can be followed and reinforced, and resources to support the training workshops. You can extract reference material directly from the manual, which you can put together as a handbook and give it to the trainees as easy reference after the training workshop. I'd like to thank you very much for listening, and I'll be happy to answer any questions at the end of the webinar. Thank you.
Thank you, Ciku, for a wonderful presentation. I think just running through the manual goes to show how extensively it was thought through, and what a comprehensive and simplified product it has become. I think this really will be a valuable and effective tool. To discuss its effect in itself, I'd like to now hand over to Dr. Wiafe, who will present on the impact of the primary eye care training manual in countries. Over to you, Bo.
Hello. Can you hear me now? Good morning.
Yes, Bo, we hear you. Please go ahead.
I am Bo Wiafe, working as a technical advisor with Operation Eyesight and the chair of the Primary Eye Care Working Group, as introduced by Simon this morning. And as we heard earlier, Ciku has actually presented a lot of things. I just want to remind you that the aim of the course is to strengthen the ability of primary level health workers to successfully manage patients with eye complaints presenting at primary healthcare facilities. As you all know, most of the troubling issues is late presentation of patients. And a lot of them, unfortunately, come from our own colleagues, the frontline health workers. And so I'm so excited that this document is going to be rolled out, and we help them to actually get empowered to do something about it. Before we go on, I think, like we heard earlier, you found out that a lot of people, or all those who go through this course, will be empowered with the knowledge. And because they know what to do and what they'll need, they will definitely help. And when they're planning their activities for the year, include essential medication and make sure the appropriate supplies and equipment are available. They'll also make sure that once they identify and understand the nature of the condition, if they cannot handle, they'll know exactly where to refer them to for assistance. Once they have done this, because the course also takes them through information system, how to collect data, so that we do not miss any information. So, because of this, the health system improvements will happen in health facilities. When you look at the human resource, we have improved skills of health personnel at the facility level. We also have, in the program presented by Ciku, we saw that there's also something for how to create awareness among the communities and how to educate the caregivers and the patients. And so there will be improved patient knowledge or caregiver knowledge. Once these are there, this will lead to appropriate and timely treatment and management, so that something very simple will not go until it becomes blinding. There will be improved patient or caregiver knowledge, so they'll know that this thing happening, I have to get up and go. There will be improved patient caregiver satisfaction with their services, because patients come there, we don't send them right away. We try to do something to help them at the primary level. Then there will be, because of that, there will be improved utilization of the eye health services at the community level. As a result of this, you find that efficiency of the health workers are improved because patients come because they know what to do. They will be able to do it quickly and see more patients in a short time. The quality of care will be improved. Morale of the health workers will be boosted because the quality of care has improved at the facility. Imagine someone with cataracts who comes to the facility, they diagnose them, but they cannot do much more. They refer them. When they come back from the hospital with their sight restored, it's actually a morale booster for the health worker who actually started the whole identification and refer them up. In summary, there is improvement in case management skills of the health worker in iHealth. There will be improvement in the health system support required to provide quality iHealth services at that level. Then improvement in iHealth seeking behavior of communities, which currently is very minimal. The impact that we are looking at seeing is that avoidable blindness eliminated from communities, and that communities enjoy quality vision for as long as possible. Thank you so much for your attention.
Thank you, Bo. Again, a wonderful and comprehensive presentation. We've had quite a few questions coming through, which are great. I have been compiling them as I can. I think, the questions are still coming through, so perhaps I can pose some of the questions to our presenters, and we can move forward from there. So, first off, we have two questions from the esteemed Claire Gilbert, and I think those I'd like to pose to Ciku if I can. Ciku, a question from Claire. It seems as if the manual for primary healthcare after training needs is, I beg your pardon. It seems as if the manual for primary healthcare after training needs to be put together locally. Is this correct? If so, can a core manual be prepared to ensure that it has all the key elements?
Thank you, Simon, and thank you, Claire, for that question. I would consider what exists today as the core manual. What we've done is left the intervention bits flexible. As an example, I would say, for example, when it comes to something like near vision, in some countries like Rwanda, for example, the health centers include reading glasses as part of their essential drug package. It means that a country like Rwanda would then want the nurses to dispense the reading glasses. That is not the case in Kenya, for example. And we just left it as an either or, depending on what is specific to the country. So those sort of customizations would happen at the training workshop stage, where, for example, if you want to prescribe an antibiotic for conjunctivitis, you would have to determine which is the antibiotic drop that is easily available in each specific country, which is the anti-allergy drug that is easily available. So I think what exists now is what I would consider as the core manual.
Thank you, Ciku. A second question, and this is this is probably a more practical question, but certainly one that ought to be given thought. Color printing is absolutely essential, but will dramatically increase the costs, but, particularly for the thousands of primary healthcare workers which need to be trained. Is it possible to construct a black and white friendly version by using shades of gray or some kind of background pattern? Claire, I might take that. I think this is something that we can certainly put to WHO. The document has obviously just been released in June, and it's published on their website for everybody to download. I think it would be resource dependent as to whether or not WHO will actually print these documents and disseminate them themselves. And I think that's still under deliberation. But I agree indeed that color printing certainly is more expensive, and a black and white option is quite considerate. I think another question for Ciku from Abdallah Kunia. Is it okay for an optometrist to use the manual to train primary health workers?
Yes, an optometrist, depending on what you are allowed to do and not do in your country, is an appropriate person to train. However, like I said in my presentation, we would like you to be absolutely familiar with what the rationale behind the manual is and what is possible in the country where you want to do training. So in terms of who are the appropriate people to train and what are the appropriate skills that they are allowed to have and can practice. But anybody who has skills in eye care more than a primary health worker can use the manual. Just ensure you have the right trainers, the master trainers in your country.
Thank you, Ciku. Next, a question for Bo. What can you advise someone who is thinking of using the training manual, but who is training primary school teachers as the PEC personnel?
Yeah, I think thanks so much for the question. I think for the primary school teachers, they can still extract sections that is appropriate to their needs, looking at the basics of vision taking, visual acuity taking, and then the basics of an eye, and not extensive, because basically we want to make sure they'll be able to identify some children with defects in vision and refer them up or prepare them for the school health services program. So it can be used, but sections can be extracted and adapted to their needs. Thank you.
Simon, if you would allow me to add something.
Of course.
Yes, Bo is absolutely right that if what you're teaching the teacher is how to test vision, then you can pick out the protocol from the manual and use it for training. But if you remember at the beginning of my presentation, this is a manual for health workers. So a school teacher is not a health worker. So you have to be very careful in what you are asking them to use this manual for.
Thank you, Ciku. Another question for Bo. To be scalable, PEC needs to be included in pre- and in-service training of primary health workers. Has this been explored anywhere? How can PEC be included in this training in the region?
Well, I think because it has not been strengthened, I mean, the PEC has not been strengthened at the pre-service level. That's why we're doing all we're doing. And so I would suggest that it should be able to be used at the pre-service level, meaning in nursing training schools.
And if I could add something, Simon, actually in development of this manual, it can be used for in-service as well as pre-service training. So the same 3-day course can be run as part of our nursing school curriculum. And we did pilot that and it worked quite well.
Thank you, Ciku. All right, I think I have just 2 more questions. The first is probably to Ciku. I have a question on the children's algorithm. Does every child need to be referred urgently, whatever the problem, as the algorithm ends in red on every problem?
I think the last tree of the algorithm, there is one where you are treating conjunctivitis and you would only refer if the patient is not improving on medication. So for example, a child who presents with a sticky eye, we think a nurse should be able to treat that with antibiotic available to them. But it means that you should be sensitive to reviewing the child, and if they're not improving on the only medication available to you, then certainly you should refer. The other conditions are things that we believe at that level, it's not correct that should be the decision-making health worker, for example, for a child with a squinty eye, and definitely not for small babies below the age of 3 months, because eye conditions can progress rapidly and there's a real risk of permanent loss of vision in that age group. That is why that algorithm is hotter than the others, so it's more red.
Thank you, Ciku. I think I have one question which I'll put to the both of you. Do you think this manual can be applicable to other regions? In this particular case, Eduardo Marioga has asked whether it could be applicable to Latin America. But do you think this training manual is applicable to, can be applied in other regions?
I let Bo answer first.
Of course. Bo, would you like to answer?
If I can go first. Yeah, it should be applicable because they also have primary eye care needs. And like Ciku mentioned, there were participants from outside Africa as well. I mean, experts. And so it should be able to be used there, but adapted to their situation. Thank you.
Thank you, Bo. Ciku, do you have anything to add?
I would say Bo is absolutely right. Eye care is the same whatever region you're in. And this manual has been left very customizable. So for example, the algorithm that deals with the lid, if you are living in an area that has trachoma, you can apply that algorithm and still end up to an intervention for a patient with trachoma. If you don't have trachoma, you don't have to follow that branch. Every other thing, I think, is common presentations that you would find in any health facility. So I would say absolutely applicable, just customized to who your primary health worker is and which medications are available and the scope of practice for the health workers that you have.
Thank you, Ciku. There are a few other questions which I think I'll tackle as IAPB. We have a question from Ecuador, and the question is it possible to have this protocol available in Spanish? Currently, the document has just been released in English, and WHO is in the process of having it translated into French. They will then have to pilot the translated version, and they're hoping to have the translated version launched by the end of this year. Thereafter, given that this is a document primarily for the, or at least at this point for the African region, they would aim to translate it into Portuguese thereafter. Certainly, I think there is scope for it to be translated into other languages, but I know kind of just as far as the aim right now, it's translated from English to French and then to Portuguese. Spanish may not yet be on the radar, but there's no, I think if resources were available, this is something that could be done. The next question is, it's two sets of questions. Could we make a link available for the manual, and also could we provide a link to the list of recognized trainers? Now, WHO has yet to train a list of the certified registered trainers, but once they have been trained and are available, we certainly would put that list on the IAPB website. As for a web link for the manual, you can find the manual on the WHO website itself. So if you simply type in primary eye care training manual, it's available on the WHO website. And then, of course, once the list of trainers is available, we would also promote those on the IAPB website and the IAPB Africa newsletter. We have one last question from Nigeria, and it is how can WHO in this case help with advocacy to the ministries of health to integrate this package into their primary healthcare systems? Now, I think certainly with WHO, if countries sign up to a document such as this, then you could take it to your ministers and into the ministries and remind them that this is a WHO document and sort of promoted by WHO, which is of course the leading authority on health. Also, the IAPB itself has an advocacy program where we aim to advocate, well, where we advocate for the integration of eye health workers and eye health services into broader healthcare at the national level. So if this is something that you would like to explore, please do contact me and we can discuss this further. I think just that perhaps brings our formal presentation to a close. I would just like to add a few comments on where we are with the manual and what's going to happen with it in the future. Now, as I said, it was launched in June of 2018, and what launch means is it's been made publicly available on the WHO website. So you can certainly go there and you can download it. And it's ready for use. As I said, currently only available in English. It's being translated into French, and the time frame for that is for it to be available in French by the end of this year. And resources depending, it should be available. It should be translated into Portuguese thereafter. Now, in terms of a more formal launch. IAPB and WHO AFRO are looking to hold a joint workshop, also partnering with other IAPB members in October or November of this year to sensitize the Anglophone countries in sub-Saharan Africa on the training manual. So if anybody is interested in being a part of that, please do contact me. You can find my details on the IAPB website. And WHO itself is looking to hold a training of these registered trainers who would then be made available to countries and anybody who would like to use them to undertake a training on the manual. As I said, this training has not yet taken place. It's expected to take place sometime this year. And then we would release all details on that. So I think anybody who is interested in that, please keep an eye out for the IAPB website. I beg your pardon, for the IAPB newsletter, which comes out quarterly. We will certainly provide updates there, and we will also provide updates through our other media outlets, on the IAPB website and even via social media. Just to let those of you know, we really did have a great response to this webinar, and as a result, we record all of our webinars, and this will be made available on the IAPB website on Monday. We will also include a link to the manual itself. So for those of you who aren't going to search for it on the WHO website, it'll be available on the IAPB website as of Monday in a link. I'd like to thank everybody for listening and for logging on, but primarily I'd like to thank our two speakers. I think honestly when we kind of first conceived the idea of a webinar on the primary ICAM manual, we thought who were the top 2 people who we'd like to have present, and our 2 presenters, Dr. Mathenge and Dr. Wiafe, were our first choices, and we were delighted that they were able to take time out of their busy schedules and able to present. So we really feel that they're the best possible people to have informed you on this particular document. Finally, I'd like to thank Emma, who none of you have met, but Emma is the background, and she runs the mechanisms of these webinars, and this has gone without a hitch. So thank you to you, Emma. And really, I think at this point, I'd say that's it from us. Again, we have been delighted with the turnout. It's been another record for IAPB and a record that's been set by Africa. So thank you to all of you for having joined in. Please do keep an eye out for the next webinars, which we'll promote as we have done this one. And we look forward to engaging with you all in the future. So thank you to all, and I'm signing off. Thank you, and bye-bye.
Thank you, and bye.